Thank you very much, sir. And it's again a pleasure to be with Dr. Samuel, sir, there. And although I did not work under you, but every year I have learned so many things from you in each of the meetings. And whatever we are today, it's all which we have picked up from you. And I thank Deepak and the organizers for calling me and giving me opportunity to be one among you here. And with all this, I think we'll go to the topic today. Coronary artery dissection. Coronary artery dissection and classification. I'll show you some cases, and in between I'll tell you how to treat such cases, because there is no real literature recommendation for dissection per se as such, or there are not much of guidelines there. So with this, what is a dissection? So dissection is something like which is a tear in the intima of the coronary, and it ranges from luminal staining to total occlusion. Very important cause for abrupt vessel closure, and it can extend into the media, adventitia, and sometimes beyond, where it can land up in a perforation. So this is a broad classification of a dissection. Coming to classification based on angiogram, this is NLHBI classification. This is type A, type B, type C, type D, type E, and type F. Depending on the extent of dissection, this is only a luminal haziness, but the contrast drains off at the end of the injection. And there might be two lumens or parallel lumens here in this. There might be a contrast extravascular compartment. This is type C. And type 4 is spiral dissections. And here there is a defect which is persisting even after the dye clears. So this is the persistent filling defect, and it's a total occlusion. So there are 5 types of dissection based on angiographical classification. Coming to etiology, very important thing is most of the dissections are iatrogenic, and there is a spontaneous coronary artery dissection, which is also important, but it is not so common. But you should be aware of this, and recognition is also very important. I'll show you a few cases of that also. Coming to SCAD, that is spontaneous coronary artery dissection, it's a non-traumatic, non-iatrogenic separation of coronary arterial wall, very common in younger women. The basic pathology is there's an intimal tear or bleeding into the vasa viscerum, and then the medial hemorrhage, the hemorrhage extends like that, producing a false lumen or compressing the main true lumen. And this is what is the main pathology there. And there is a classification for SCAD also. Type 1 is multiple radiolucent lumen defects. Type 2 is diffuse long lesions, where it is very difficult to recognize. And type 3 is very tricky. It is focal, less than 20 millimeter, but most of the time it can look like a atherosclerotic block. So this is the classification. This is type 1, where you see a small luminal defect, and type 2, where it is a diffuse long thing. Most of the time you might feel it is a spasm, and you give IV NTG, just rule out spasm, and then you consider this. And it's a very focal lesion like this. You really cannot make out whether it is atherosclerotic or what, unless you do an imaging in such cases. So these are some of the predisposing causes for SCAD, starting from fibromuscular dysplasia, pregnancy, and systemic inflammation disease, and all those things. And they look at this angiogram here. So there are some intraluminal filling defects. We might think it's a dissection, or we don't know. Angiographically, it is very difficult to make out what is this. So what I did is, we have few cases like this, but I'll show you one example. We did an imaging in this case. We thought it is a spontaneous coronary artery dissection, but for your surprise, you see here, it is actually a recanalized thrombus. This is what you see on an OCT, where you see that latest root appearance, where it's a recanalized thrombus, but just angiographically making out is very, very difficult. And this is a case here. You see a similar intraluminal filling defects there, and starting from here to here. And again, we might think it's a SCAD, or we might just leave it as thrombus. But if the patient is hemodynamically stable, most of the cases can be left on medical management. Issue comes as if there is active ischemia or hemodynamic instability. So even here, you look at the imaging in this CAD here. So there is nothing inside the lumen, unlike the previous case where it was a recanalized thrombus. The lumen is completely free. But when you concentrate at the wall of the artery, see there is a break in the intima and there is an hematoma which is coming here. So this is what is creating that. So this is a type 1 SCAD patient with presenting like something like an anterior wall MI. And the luminal area is very good. Patient was hemodynamically stable. So you just can leave it on medical management. So for an algorithm for SCAD, you do an angiogram. Type 1, if you are very sure, then it is SCAD. And if you're not very sure, then if it's type 2, if it's a diffuse disease, probably give nitroglycerin, rule out a spasm. And if there's any doubt, if it's a very proximal vessel, you can do imaging. And type 3 is very tricky. It mimics atherosclerosis. Many times we would have stented it, but probably it may not be atherosclerotic. It might be an SCAD patient. Unless you do an imaging, it is very difficult. But it is not a must that you should do imaging in all SCAD, because for entering the true lumen might be difficult. And if there is a need for intervention or if there is a clear doubt in diagnosis, then you can do a OCT, or if IVUS, then you can come to a conclusion easily. And this is a treatment chart for SCAD there. Basically what this busy chart says is, if hemodynamically stable, leave it, put him on medical management. Otherwise, consider imaging, diagnose it, depending on the hemodynamic instability on IABP or other support device, and go ahead, stent it, or sometimes, very, very rarely, they might require a bypass surgery. I'll show you an example, a very interesting case which I came across. You just look at this angiogram. This was the angio to start with. So what I have done is, this was a patient who came something like an anterior wall ischemia, and lesion very typical. It is a very discrete lesion. I thought we'll go ahead and directly stent it. And I did not do any imaging, and then it was very clear case. And I asked my junior, you go ahead, directly stent it. So we just stented this patient like this. Once we stented and we were post-dilating, what was happening is, I dilated the distal part of the stent here. It expanded and then came to the proximal part of the stent for dilatation. Once we dilated the proximal part, again the distal part, the stenosis was appearing. And then you see here, the distal part, again the stenosis has occurred, but the proximal is expanded. And once we dilate the distal again the proximal part, there is a stenosis. So you can see here, there is a stenosis which is extending into the proximal here. So what happens is, whenever you balloon the distal part, the proximal part, it becomes stenosed. If you dilate the proximal part, the distal part becomes stenosed. So it is something like it's a shifting stenosis. We really were really puzzled what it could be. So this is what is happening. See here, dilated the distal part, and again the proximal dilated, again the distal becomes narrow here. So this continued to happen twice or thrice. Then I thought we should do some imaging there, and then we went ahead with the imaging. You see here, it's a clear hematoma there. Although on that day I could do only an IVUS, I couldn't pick up the intimal tear because we had already stented the patient. But it was an hematoma which was moving between the false lumen, producing the compression in the stent and creating this. So this is a type of spontaneous coronary artery dissection producing this. Then I had to put a long stent and then treated this patient which got stabilized later. And post-procedure IVUS showed the entire lesion was covered well and went on fine. Another important thing is, next part of dissection is a guide-induced dissection. And it's very uncommon, but it can be devastating. Incidence is unknown, and it can be an antegrade dissection or a retrograde dissection. Predominant risk factors for guide-induced dissections are left main disease and calcification. Be very careful. You should size the guides properly, and then you should keep it coaxially. Unplatz-shaped catheters, more incidence of dissection, and the way you manipulate the catheters are very, very important. If there is a vigorous contrast injection, it's a risk. Deep intubation and variant anatomy, especially anomalous coronary, it is very difficult. And very deep inspiration or coughing during the procedure is a problem. Most important thing is the dissection, you should recognize it. The earlier you recognize, the better the prognosis. And you use appropriate size of catheters and the shape of it. And direct contrast injection into the plaque should be avoided from the guide if possible. And initial contrast injection should not be forceful until your guide catheter becomes well aligned. And you should avoid injections whenever there is significant pressure damping in the guide. So these are some of the important points you should remember when you are using a guide catheter to avoid it. And there is a classification for that, depending on the aortic wall dissection. Class 1, Class 2, Class 3. It is, Class 1 is it involves only the cusp. Class 2, it extends to the aorta, but less than 40 millimeter. And Class 3 is extend to the aortic wall, but beyond 40 millimeter. This classification is predominantly useful for risk stratification. Class 3 has the worst prognosis because probably they might not survive or you might require immediate surgery for better outcome. And coming to the therapy of dissections, one is very important is recognition is very important. And if there is hemodynamic instability, probably put some IABP or Impella, whatever you have there. And very important is soft tip should be put into the true wire, true lumen. The wiring the true lumen is the very most important step in the treating guide catheter dissections. And you should always confirm that you are in the true lumen. And if you feel if you are in the true lumen, then you go ahead and stent it. And if you feel it is in the false lumen, try to rewire. Many times you come back and keep trying with from the proximal part. You can enter the true. This is one trick you should remember. Have little bit of persistence. Try once or twice so that you try to get the true lumen. If you cannot assess it, then probably the option is only bypass surgery. And if there is retrograde extension, then depend on the hemodynamic stability, you go ahead and treat these patients with aortic dissections. See, this is an example of a patient who had an RCA lesion. We try to treat it with a Amplatzer guiding there. Once the Amplatzer guide was put there, this patient tend to have a significant dissection there. But luckily, the wire could be passed and then patient was stented and he has recovered there. And look at this patient. Look at this patient. He had a borderline to around a significant lesion in the mid RCA. And what has happened is, so this is the lesion. We were just stenting this RCA here. And once stented, you look at this angiogram, there was the guide has been probably pulled inside. And then there is a significant proximal dissection. This is a guide-induced dissection, probably guide deep-throated, or when we try to remove the balloon, guide has come in and then it has dissected. So this case, there was a stent here. So what I have done is I did a OCT there. So you can clearly see that this is the intimal tear and this is the hematoma there. And this is compressing the true lumen here. There is a significant contrast staining which is still remaining. And this is the staining of the false lumen there, which is persisting. So with this, the only option is I had to put a stent there and then covered it. It was a very straightforward thing and there was no issue. This type of stent dissection, when the wire is there and then you recognize the dissection very fast and then you do it with the image guidance, then there's no problem. Then technically it is not a big issue. It is a straightforward procedure. And of course, post-stenting, role of imaging here is, one important thing is, you get the exact sizing of the stent, which is very difficult to define it just with angiogram when there is a dissection. And when there is an hematoma compressing the true lumen, many times you try to undersize the stent, like probably at that point when the hematoma resolves, you might land up in Mahler position. So that is the role of imaging. You can exactly size the stent and probably you can even expand it so that you compress the hematoma properly so that your long-term results are good in this. Similarly, this patient again was a very straightforward lesion, RCA lesion, and we wanted to put it, but unfortunately the moment the guide was put, this induced a dissection, and you see that it is a spiral dissection extending till down, and there is no flow here distally. And this is a guide-induced dissection. And before we could put the wire itself, it is dissected. So here it's a very important point. Now, how to wire this? Your main target should enter a true lumen. So what we did is we tried with so many wires, and patient naturally when there is a dissection like this, they tend to have ST elevation and chest pain. And here, with after a great amount of effort, trying to enter the true lumen, I could enter the true lumen here, and then we have reached the true lumen. And once you get the true lumen, then the job is easy. You go ahead and then enter that part. And once stented, then it is quite stable now. The patient is stable. And you see that although the flow was disturbed here, when you just proximal entry point, when it was stented, flow has become, and it has produced a good TIMI3 flow here. And then after this, I did an imaging. As I already told you in the last case, what is the role here is to exactly size the stent and to compress the false lumen and to reduce the hematoma. This patient was stented and with excellent result with OCT guidance. And we did a post 3 months checkup also for this OCT guided. We wanted to know what happens to the stents there when there is a dissection like that. It was an excellent result. Only thing there, distally, there was some thrombus, which we did not do anything at the follow-up at 3 months. Stent were well opposed, and it was excellent flow, and patient was totally asymptomatic. And this is an example. This is a patient who had unstable angina. This is the left-sided lesions you see there. And when they wanted to do an FFR in this lesion for a borderline lesion, you just concentrate on this point here. There is a flap here at the left main ostium itself. And just because of that, LAD, which did not have a lesion in the proximal segment, it has probably a dissection has extended, or the hematoma which has extended, compressing the LAD, and patient became unstable. And somehow again here with difficulty, with the same guide, the true lumen was fired, and then patient underwent stenting with good results. And what is the role of imaging in such dissection? See, look at this patient. Again, he had a proximal LAD lesion. Once the guide was there, he developed a left main dissection extending into the LAD. And once that happens, you look at this IVUS image. So you concentrate from the distal part. So when you just concentrate here, you see this is in the mid LAD, there is a significant disease. That is what they wanted to check with FFR, but unfortunately landed in dissection. Then you get a true false lumen, and this is a true lumen, this is the false lumen. And this false lumen is compressing the true lumen. And when you come up in the left main, you can look at the flap there, and then this is the dissection, which is compromising the LAD there and producing this problem. This IVUS might help you, like if you are unable to enter the true lumen, with IVUS guidance, you can go ahead and identify the true lumen. But technically it is demanding, but here it could be fired, and patient was stented and with good results. And next, coming to wire-related dissections, this is an example. This patient recently had an inferior wall MI some week or 10 days back. That day night, we did a primary angioplasty for him, and RCA was stented, and he had a complete outblock. So he was on TPI, and this was the final angiogram at the end of the primary PTCA, where this RCA was totally occluded. This is the final check angiogram, and then he was shifted to the ward. Next day morning, again, he developed chest pain, and when we developed complete outblock again. And you'll see here, the stent is totally occluded here. It's acute stent thrombosis. We were really, but since it was this COVID time and middle of the night, we didn't do any imaging at that time. And we put a wire and we established the flow. The moment I put the wire, the flow was very clear. And after this, you see here, probably there was some wire-induced stent edge dissection here, which was the reason for a stent thrombosis, which we did not recognize the previous night. And immediately that part was stented and stabilized. And patient is stable now. He has almost, he's fit for discharge. And see, it was done very recently, and then he has recovered from that. He's still in the hospital. Probably tomorrow or something we'll be discharging him. So this patient had a significant LAD lesion here. And we went ahead and stented the proximal LAD. And there was difficulty wiring this lesion because it was almost like a total occlusion, and then it was a calcified lesion. And we went ahead and stented the proximal segment. And once that proximal segment was stented, this is what you see in the distal part. So proximal LAD stented, but here there is a long dissection extending from here to here. What to do in such cases? So you cannot stent from here to here, or can you do any imaging there? You cannot take the OCT catheter there. So you, in such cases where it's a very distal disease and you observe if the patient is hemodynamically stable, you need not do anything. You can just leave him for medical management. Many times I have seen that when you call them after 3 months or so, this type of dissection has healed. Or what I have seen is there will be a total occlusion of LAD which will be recanalized or collateralized from the other vessel. That is what I have seen when we follow up such cases. If hemodynamically stable, don't worry, because you cannot stent the entire vessel. It's a diffuse disease there. I just leave him for medical management. So he was just left for medical management and just followed it like that. A case here, we stented the LAD here, a very young lady, and severe triple vessel disease, but I had to, came with anterior OLMA, stented the LAD, the proximal LAD stented, and then after the LAD, we did the OCT study, and you see it was excellent in OCT. There was no stent edge dissection, full stent expansion was there. But when you look at the angiogram, what was seen is beyond the stent, there is a lesion here. So many times you have to give importance for the angiogram where there was a significant distal dissection, which was a wire-induced dissection, nothing to do with the stent. The stent from the edge, when we studied, was normal. So probably it was a stent edge dissection, which was stented by, again, with another stent. We had to overlap it, but anyhow, the patient recovered well, and this is the final angiogram. The patient is doing well. So guide wires manipulation and type of guide wire is also important. So it can dissect a vessel and create problem. And when you are treating dissection, just remember the very important point is entering the true lumen is very, very important. And extension of intra hemorrhage, that is intramedial hemorrhage, can be antegrade or retrograde. It can lead to sudden vessel closure. And if it's in a small vessel dissection, very difficult to do PCI. Large vessel dissection problem is it can be malopposition over a period of time when the hemorrhage is dissolved. And longer stents you implant, many times that is what we do in long dissections. The incidence of ISR is very high. And things you should remember is, if there is a focal stent dissection, you should cover both distal and proximal segment. That is very important. If it is a long dissection, try to stent distally, then proximally, and finally in the middle part, so that you don't extend the dissection. That hematoma will not extend, so that stents at the both end will prevent that hematoma extension. And intravascular imaging especially is very, very useful in sizing the stent. At the same time, identifying the true lumen, especially IBUS for true lumen, and sizing, and then looking at the intimal flaps. OCT is excellent, where you see the true lumen intramural hematomas are very clearly explained by an OCT. And as I told you, stent deployment, DES, and then identifying the obliteration of false lumen is very important step in treating a significant dissection. And coming to balloon related, of course, each one of us would have come across. I think Samuel Sal would remember his old days where only plain balloon angioplasty. We know that when you do that plain balloon angioplasty, what happens? Most of the time you land up with dissections, but 50% of the time they land in reocclusion. Many times we'll do away with that without any problem. And this treatment is straightforward. Go ahead and stent it. And another case here, left main bifurcation, where you see that there was a stent deployed from LAD to left main to LAD crossover in that circumflex lesion. Once that was done, the circumflex got occluded and patient became unstable. So probably there was a dissection somewhere here as extended here. We don't know what was happening. And we had to rewire the LAD, LCX very quickly. And then I put probably a TAP or a T stent. This was done under emergency. We couldn't do any imaging because patient was sick. And then after stenting that, I went ahead and did a OCT to see what was happening. So this is what I could see. The stent was well deployed, but in the proximal segment in the LAD, there is a significant dissection here, which initially I could not pick it up on an angiogram. But what we could make out is suddenly that LCX closed. This is the same example what Dr. Matthew sir was saying in Natarajan sir's case. When he was treating the proximal LAD, probably some dissection like this from the left main would have closed that vessel. And that was the reason for that sudden collapse of the patient. This is also a similar thing, but documented with imaging. Angiographically, we couldn't make out. We thought is it thrombus or something, why this LCX is occluding. But it was a very clear dissection, as rightly Matthew sir pointed out, something there from there as a dissection has extended. A similar case, you see here, dissection in the left main. So this is the part we are seeing here. Stented area is here. In the left main, you see here, it's a big dissection causing this problem. And then once this was identified, then it's straightforward. You can put a stent there. But now, since we have stented the LAD and the LCX, the patient is stable. Sometimes we have just left this also because proximal dissection generally does not extend beyond the stent. It can be put for medical management. But in a left main, such a big dissection is controversial. It's always ideal to stent it and treat it if feasible. And this patient, this is the angiogram. Then when we were doing the OCT, we observed here very clearly, and then we could make out there is something there. But initially we couldn't make out, but we could notice only the circumflex suddenly closed. So we don't, probably this is a left main dissection extending into the circumflex, which has closed, and the patient was finally stabilized, went home well, and even now she's doing very well. And these are one of the certain things we should remember is, especially when you are treating ISR, balloon dilatation creates different types of dissection in the ISR segment. And especially if you are using a drug-eluting balloon, producing this type of dissection voluntarily is very, very useful. Because in this ISR segment, when you dilate with this balloon, after this dissection, so when you use a drug-eluting balloon, the penetration of drug is supposed to be better to prevent restenosis, but it's all theoretical. And some senior people, like I have met few people in Europe and China, they advocate that you just nicely crack it, produce a lot of dissections, and then you put a drug-eluting balloon, results will be good. And coming to very important part of dissection is stent edge dissections. So what is important in this? Most of the time, our problem, that is stent failure, stent thrombosis, are all because of stent edge dissections, which are not clearly recognized. And reasons for that is, if there is a greater balloon to artery ratio, if it's a calcified lesion, long lesion, and number of balloon inflations, plenty of inflations you do, chances are high, large disease burden. And very, very important is selecting the landing zone. That is what we give a lot of importance today with imaging. You should select a place where the plaque burden is less than 50%. It should not be calcified. There should not be significant lipid-rich plaque at the landing zone. These are all some of the, and you should, if there is a thin cap atheroma near the landing zone, better include that also. If you do all these things, probably your incidence of stent edge dissections will be less. And stretch, overstretching and calcification angle, all those things are important. But practically possible things which we can do is identify the right spot to land your stent is very, very important. And stent edge dissections, if the lumen is bigger, according to OCT, if it is more than 4.5 MLA, or according to IVUS, if it is 5.1 and more, then the significance is less. But lesser lumen with significant dissection is very dangerous. So this is how you make out the dissections. So dissections can be intimal, medial, or intramural hematoma extending it beyond the adventitia also. So this is the intima. This is how you see on an OCT. See, artery has 3 layers: intima, media, and adventitia. So if there is, the disruption is just limited to intima like this, it is called as intimal. Time to learn, because there is some amount of learning curve there. So this is how the dissection looks in an IVUS. It's the same patient, 2 images, and this is how the IVUS image looks. And this is the OCT, and you see here, this is extending into the media. So when it is extending into the media, it's a medial dissection. And you see here, it's a dissection here in the IVUS going up there. And this is the intramural hematoma. You see here, this is the hematoma very clearly demonstrated on IVUS. And this is the break in the intima, where blood has come here and produced the hematoma causing this. So this is the differentiation between IVUS and OCT. And OCT gives excellent images of dissection. And important thing, what you should know is the degree of, as I already told you, whether it is limited to intima extending into the media is very important to make a treatment decision. And you should know the extension of this. You look at this, for example, you divide this circle into 4 quadrants. And if it is more than 60-degree extension, then you call it as it's a major dissection. If it is less than 60 degrees, something like this, which is less than a quadrant extension, then it is a minor degree of dissection. That is one point. And length of dissection is important. How to make out length on an OCT is you should look at this longitudinal images. You see here, you measure it. Generally, stent edge dissections are dissections which are around 5 millimeters in and around the stent. So any dissection, see there is a dissection here, you can measure from ear to ear, know the length of the dissection. Keeping all these 3 important things, we classify dissections whether it is major or minor. Major dissection should be treated, minor can be left. I will tell you in detail in next slides. So this is an example of intimal tear and hematoma extending there and producing a dissection there. This is a similar OCT IVUS representation of this. And there are trials, when you compare IVUS and OCT, major dissections were identified into more times in OCT, and both major and minor dissections, both were identified by OCT in a better way. And when they followed up, when somebody has a dissection, target vessel failure is high, death is high, and then incidence of MI is high, and MACE is also high, even there is a dissection. If there is no dissection, this incidence is lesser. So you should recognize a stent dissection and treat it properly. So what dissection needs to be treated is called as major dissection. If the dissection is extending beyond 60 degrees, if it is beyond 3 millimeter, if there is intramural hematoma, if inadequate MLA, that is according to OCT, if it is less than 4.5, according to IVUS less than 5.1, and if the TIMI flow is less, then it is very, very important. Distal dissection is more important compared to proximal dissection. Medial dissection is more important than intimal. So just remember this whenever you are using an imaging to make a decision whether to treat this dissection or just leave it. Remember all this point. It will be of great help to produce better results. The ESC recommends the same thing. This is look at the dissections here, less than 60-degree flap limited to intima, less than 2 millimeter. So you can leave this type of dissections because many times OCT detects very small dissections which can be left alone. You look at this patient, he had a stent, and look at this OCT here. At the edge of the stent, there is a dissection here. You can see it in this run also. There is a small dissection there. This is a very minor dissection which you need not treat, can be just left for follow-up, nothing happens. And many times such minor dissections you cannot make out on the angiogram. So if something becomes some haziness at the edge of the stent on an angiogram, usually represents significant dissection. That is your practical tip. If you cannot see anything on the angiogram, that is probably a minor dissection. Even mild haziness, mostly it is major dissection. But after saying that, many times we have picked up on imaging where angio doesn't show anything, but you get a major dissection on imaging. That point is there. But I mean to say is, if you can see it on angio, definitely it's a major dissection. You'll have to treat it. That is an important point, takeaway point that you should remember. Look at this interesting case. This case was referred to me by my friend. He was treating this patient in VIP. He had an inferior wall MI for which he stented the circumflex. And the same day evening, this man had stent thrombosis. Then he did a stent thrombosection. And then he saw this angiogram was completely normal. But since he being a VIP, and then he thought we need to do something for him. So he referred this patient to me for imaging. So what I did is I took him up for the angiogram. Look at this angiogram, looks like this. This is perfectly normal. I couldn't make out anything abnormal on the angiogram. But when I did the OCT, you see here, what is happening is there is a clear major dissection in the distal part here. And this is almost more than around 3/4 extension of dissection, and then producing a false lumen, then compressing the true lumen there. And then the stent is here. And this man had malappositions in the middle of the stent. And he had one proximal dissection also. So this is the proximal dissection where I have just filled it. You look at this, you can see the proximal dissection also there. Yeah. So this man, one single case, he has all reasons for stent thrombosis. Stent edge dissection distal, which is very major, not seen on the angiogram. Angiogram looking normal. Malapposition, under expansion here, and proximal dissection, all in a single case. So what I had to do is, only thing is, I know the reason now why this patient had the problem. I stented the distal dissection from here to the proximal part also was stented and producing an excellent result, and this patient is doing fine. So very important thing to conclude again for you is, when there is an eye-reducing dissection, and try to avoid further antegrade injection into the same guide. So be slow on injecting. Only if there is a necessity, give a small injection. Or you put some catheter like over the balloon, over the wire balloon, or some microcatheter. Just inject slowly beyond the dissection. And if there is hemodynamic compromise, like one of the circumflex occlusion, or like Natarajan sir's case, put IABP or Impella if it is available. And use a passive guide. Don't try to deep throat inside the same dissected segment. Try to keep the guide out and try to enter the true lumen slowly, and attempt entering true lumen with non-hydrophilic wire. But many times I have used hydrophilic wire and been successful. That is your experience, operator experience. Might be Matthew sir will give us more idea what type of wire to use when there is a dissection. And if possible, use IVERS to make out whether it's true or false lumen. And you try to wire the true lumen and stent implantation. And if you cannot wire it at all, there are circumstances which has happened where I have dissected the left main ostium, tried so many times, couldn't do that. We had to send them for emergency bypass. All those things are possible. So be careful, keep all options open to produce better result. So to conclude, aortocoronary dissections or guide catheters is very rare, but be careful, it's life-threatening. Careful selection and manipulation of catheters are very, very important. And reviewing the angiogram is very, very important. Diagnosing the dissection is the first point of your treatment. Like when you fail to recognize it, you recognize it late, then the problem is going to be like you will lose the patient. So you should be very, very recognize it very fast. That is very important. And prompt stenting, angioplasty stenting saves a lot of life. Bypass surgery is there, but it's very difficult. Whether he survives it or not, it's a question mark. But angioplasty, I'm very sure, if you do it promptly, you can save a lot of life, especially left main dissection when the patient is very unstable. And there are no evidence-based guidelines for this. So you will have to develop on your own experience, and like masters like Matthew sir can give us a lot of idea. I have learned a lot of things from him over the years. Now every year we used to attend his meetings and learn each meeting 1 or 2 points, and that is how we have developed now. And very few coronary dissection heal on its own, especially if the patient is unstable. We cannot leave it. Distal dissections, if the patients are stable, we can leave them for spontaneous healing. And always remember, wiring the true lumen is the Achilles heel of PCI in patients with dissection. If you wire the true lumen, the job is done. Rest is very, very easy. And imaging will definitely be very, very useful for you. Thank you.
Thank you, Selvamani. It is an exhaustive teaching session. You covered almost everything in the section, and rightfully you have told us what we should not do, what we should do, and how to handle it. Just a few points to sum up. To me, as Selvamani said, iatrogenic dissections, you can leave it alone. Almost all of them. Only, spontaneous dissection, you can leave it alone. Most of the dissections are produced by us. To some amount, it is due to our carelessness. In spite of all care, we still can produce. We have seen dissections using diagnostic catheter, which is the most dangerous situation where we are not prepared. We are doing only a diagnostic angiogram. And this very often happens to young patients with many times no disease at all. We have seen dissections engaging the right coronary artery especially, as well as the guiding catheters. My suggestion to all of you is engaging guiding catheters, be as gentle as possible. Do it only under screening. Don't do any rotation without you looking onto the screen, and don't get distracted by anything happening else in the cath lab, because you have to concentrate very much when you manipulate the guiding catheter. That can avoid many a times the guiding catheter induced dissection. If it happens, guiding catheter, whether the same guiding catheter you can use or you should change the guiding catheter, you can, is a question. If you can, usually the dissection happens when the guiding catheter engages into the ostium, whether it's the right or left. You have to slightly disengage the guiding catheter when you are introducing the wire. Otherwise, the guiding catheter will be sticking on to the area where you are producing the dissection, and your wire will keep on going there. Please don't allow that to happen. If one wire keeps going into a false lumen, leave that wire there. Don't take it out. That wire will give you a guidance where you should not go. Take another wire which you are very familiar. Selvamani already said, avoid a hydrophilic wire and use a very familiar wire which you are using, and try to direct the wire into the lumen where you would like to go away from the first wire. Then these guiding you can sometimes keep the guiding catheter disengaged in the sinuses and wire it when it is aorta-ostial. If it is a wire used, very often keeping the wire there, you should be able to get the wire into the right lumen. All these dissections, the stent-induced dissections, whether it is proximal or distal, it's either you have a lesion which you did not recognize, or because you overinflated the balloon. I have seen in my experience what happens when we select a stent. It is 1:1 stent. You say, if you want to save one balloon, let me go up little higher on the pressure, not realizing there is some part of the balloon outside the stent, which will give you trouble. Be careful. Deploy the stent. Take a short balloon. That will be much safer than trying to deploy the stent with the higher pressure with the stent balloon itself. Try and avoid that practice. If you can do that, you may save many times distal and proximal dissection due to the stent. Whether it's the edge dissections of the stent. This all comes with experience. You have to have some dissection in your life if you are doing good intervention. Be ready to accept it and don't panic. Immediately think why it should cause and try to find out and find a solution for it and try to treat it. You have very little time to do that. Get the right temperament. Don't panic. Don't allow the technician to direct you. I have seen that happening very often in the cath labs. You do one. The wire in the right place. Without the wire in the right place, there is no imaging. So dissections, the skill you have to develop, that you can develop only by driving it. And I think we have covered a very important topic. And if there are any questions, Deepak, any questions we have to address?
So just one point, sir. Dr. Selvamani has stented the mid-right coronary artery, saw that there was a dissection there and he wanted to do an imaging. At least for our junior colleagues, probably it should not be OCT, it should be IVS, because with OCT you are trying to further propagate the dissection proximally as well as distally. For a master operator like Selvamani, he can always do that. But for the junior colleagues, if you want to do imaging in dissection, probably it should be always IVS. And probably he did it because the stent is limiting the dissection distally. So probably that's the reason why he used OCT.
Yeah, I showed you two cases, no? One case where there was no stent, where we did not do imaging before stenting. OCT, you should not do in a catheter-induced dissection unless there is a distal stent. If there is a distal stent, you can do OCT. If there is no stent, probably you should not do stent the distal part and then do OCT to look at the size of the vessel.
Thank you, sir. I hope you understood what both Selvamani and Deepak was trying to explain. In OCT, you have to have a very forceful injection to get the image. That injection itself can extend your dissection further. Please avoid it if it is that situation. If it is there, that is a different situation, but it's better to avoid, as Deepak said. I think with this, we'll move on to the next presentation. The next presentation is by you.
So the next one, Dr. Yusuf, he's got some issues over there. He's got a VIP in the hospital. He'll be back with us. So shall I start with my presentation?
Please, Deepak. But I have to excuse myself. I'll be away from the chair for about 10 to 15 minutes. You please go ahead. I'll come back as early as possible.
So hoping that you'll be back with us at the earliest, because all these ones.
We will do that. I will come back as early as possible. Now Natarajan and Selvamani is there to help you with their...
Yes, sir. Yes, sir. All these 190 people are here because you are also joined with us.
Yeah, of course. Thanks to all of you. Okay. Go ahead, Deepak. Please.
Yes,